Hello, I'm Petros Grivas. I'm a medical oncologist at Seattle Cancer Care Alliance. I'm an associate professor at the University of Washington and Fred Hutchinson Cancer Research Center. I'm focusing my research and my clinical practice on genitourinary cancers with a further focus on urothelial cancer, and I'm heavily involved in clinical and translational research. We're very excited to be here with my great friend and colleague, Dr. Jean Hoffman-Censits from Johns Hopkins University. Jeannie?
Hi, thank you for having me, Petros. You and I are long-term collaborators and colleagues and friends, and it's such an honor and a pleasure to be with you today and to be asked by the team. Dr. Grivas, I see you're a little casual today. Can you explain your t-shirt for us? Oh, look at that. The Walk to End Bladder Cancer. So the Bladder Cancer Advocacy Network is a great organization that you and I are both involved with. You want to talk about that a little bit?
Yeah, absolutely. Thank you for pointing this out. And actually, I shared on purpose because as I showed you in the camera, this is the Bladder Cancer Advocacy Network, or BCAN. I have a logo in our first slide here in the middle between you and me, just as a symbolic move, because both you and me are very heavily involved in this organization. It's a wonderful foundation that was initiated by Diane Quale and her husband back in 2005, and really drives the mission of raising awareness, alertness, fundraising for research, lobbying, advocacy, policy, patient support for bladder cancer. And it's really, really wonderful to have this strong foundation to help our mission to try to cure bladder cancer. And I'm wearing this shirt for two reasons. Number one, I am really believing in Beacon's mission, and actually we pronounce it as a beacon of hope or beacon of light, as Diane mentioned. And also because yesterday was a virtual walk day. We cannot do a physical person walk because of COVID-19. So we do a virtual walk. So I thought it was timely to wear this t-shirt. So thank you for pointing it out, Jeannie, and you are heavily involved in this as well.
Yeah, absolutely. So the Bladder Cancer Advocacy Network has a wonderful website for patient information, family information, lots of great videos. I always tell my new patients, I give them the website. I say, this is a really safe place on the internet to go for information, in addition to our own Johns Hopkins website. Also, you know, Beacon, they have a lot of interest in women's bladder cancer as well, which I think is a great segue to talk about, to introduce our talk today, which is entitled Diversity in Cancer Care, Challenges and Opportunities in Women's Bladder Cancer. So it's okay with you, I'm gonna dive into these slides.
Sounds great.
All right. Oh, and by the way, I'm Jeannie Hoffman-Censits, as Petros said. I am also a genitourinary medical oncologist specializing in urothelial cancer. I have special interest in women's bladder cancer, in upper tract urothelial cancer, which occurs in the ureter and renal pelvis above the bladder, as well as what's called variant histology, so more rare bladder cancers. Petros, you want to talk about your disclosures briefly?
These are my disclosures for the past year. The left column is about consulting, and the second is the institutional funding for clinical research that we're doing. Thank you, Jeannie.
Wonderful. And there are mine as well. So we'll do a brief overview of urothelial cancer. Urothelial is the cell type, the typical cell type of bladder cancer. We'll talk about the gender gap, some implications for some of our treatments, including novel treatment, which is immunotherapy, as well as some future directions. So these are some estimates from 2018 from the American Cancer Society. And although many people haven't necessarily heard of bladder cancer, look at this slide and are incredibly surprised to see it's the 4th most common cancer in men and the 8th most common cause of death in men. And despite that, most people have never heard of this disease until they or someone that they love are diagnosed with it. As you can see, for women, it's a much less common disease and doesn't even make the top 10 for either new cases or death. Bladder cancer tends to be a disease on the surface, or a superficial disease, we used to call it. Non-muscle invasive bladder cancer is the most common. So about 75 to 80% is that kind of bladder cancer, most often usually managed by urologists or specialized surgeons that take care of this disease. Dr. Grivas and I are medical oncologists, so we become involved when the disease is either locally invasive into the muscle layer of the bladder or into lymph nodes, or when it's metastatic. So if we take a look at the bladder, we cut the bladder kind of right in half. The bladder is a big muscular balloon, and the tumors usually start on the surface or right on the inner layer of the surface of the bladder, and then they can grow into that muscle layer of the balloon. On the left-hand side, you'll see descriptions of non-muscle invasive bladder cancer. So some of you may have heard of a tool called BCG. That's a very old style immunotherapy, actually the first cancer that was ever treated with immunotherapy, that's instilled into the bladder, and then a patient will hold that installation for some time and then pass it. That's done in a urologist's office, and often sequentially over the course of many weeks. And again, when a tumor on the right-hand side is invasive into the bladder wall or locally advanced or involving lymph nodes, that's when this superficial tumor can become a more lethal disease potentially, and we treat it with something called multimodality therapy. Systemic chemotherapy followed by surgery to remove the bladder, or treatment with chemotherapy and radiation to control the disease. So what is this gender gap in urothelial cancer and bladder cancer? We know that bladder cancer is a disease that most often happens in men. Depending on the stage of disease we talk about, it's about 3 to 4 times more common in men than in women. But in women, unfortunately, they tend to present with a later stage of disease and have a worse prognosis compared to men. So when we think about the gender gap in urothelial cancer, I think all of these different factors really come into play. The first is awareness. Again, the fact that most people don't ever hear about bladder cancer until they're diagnosed with the disease, so most people aren't aware of it. The medical care that we'll get into, we'll talk a little bit more about this throughout the talk, and differences that men and women may face. The patient experience, so how do women come to their diagnosis compared to men? As well as we'll talk a little bit about what is currently known and what's evolving about tumor biology. The goal of all these different things as we expand upon them is to improve outcomes as well as improve value for women with bladder cancer. So even though men are diagnosed with bladder cancer more commonly than women, women tend to have a higher rate of death compared to men. And Petros, I don't know about you, but as far as we know, this is the only solid tumor where women actually have a higher death rate than men. Typically, you know, women are the ones that are doing better, sometimes for different reasons. Maybe they tend to go to the doctor earlier or what have you. But this is really striking and something that we recognize is very important, especially for such an uncommon cancer that happens in women. And we really don't know what could be at the root of this difference in survival, but we know a couple of things. So one is presentation with symptoms. Men and women tend to have the same presentation. The most common symptom of bladder cancer is blood in the urine, either that's microscopic or that you can see. The diagnosis and delay. Most men at the average age of having bladder cancer, which is 73, have already interacted with a urologist, you know, one of these specialized doctors that will diagnose it. Women often have a different route to get their diagnosis. The completeness of evaluation is important. The stage of presentation can be different. What are the therapy options that men and women are presented with? What are those responses to therapy? And then finally, how is tumor biology potentially different? There's also social determinants of health. This is kind of a much bigger picture, but we know that the delay in diagnosis, access to treatment, healthcare disparities, and all these issues can be influenced by gender, by race, by socioeconomic status. And at the same time, there's biology that comes into play, including the disease initiation, histology, response to treatment. So there are a lot of different factors that we believe play into this issue. And I think that's in part what makes it so complicated to truly try and measure it and to make an impact on outcomes for this disease. This is a little bit of a busy slide, but this is one of many what's called algorithms of how doctors can think about managing a symptom. So for this one, there's an algorithm for hematuria. which is blood in the urine. Depending on your age and depending on your risk factors like smoking and other kinds of risk factors, there's a different algorithm that doctors can go down in terms of working up a problem, like sending a urine culture or sending a patient for a specialized test like an ultrasound or a CAT scan, or referring them to a specialist like a urologist. So depending on the patient and their medical comorbidities or their risk factors like smoking, patients with hematuria can have a risk of cancer of about 3 to 5% if they have just microscopic blood in their urine that's found on urinalysis, or up to 23% when they see bright red blood in the bathroom. And again, the symptoms of bladder cancer, the same in men and women. Urgency, meaning you really have to go to the bathroom when you have to go. Frequency, which means you have to go all the time. And then blood in the urine, either microscopic or gross that you can actually see. Petros, do you want to jump in and talk about this slide a little bit in terms of where do the different causes of hematuria and why this is so complicated? I think oftentimes patients, even if they do come with a short delay in their treatment, wonder kind of, you know, maybe why they weren't sent to a urologist immediately with the very first time they had an episode of hematuria.
Absolutely, Jenny. I agree with you all the points you made. And I think we all have experienced situations and we hear stories about the delay in diagnosis of urothelial cancer in men and women, but even more in women, because as you mentioned, the diagnosis is more common in men. However, women can get bladder cancer. We should not forget that. And frequently, as you mentioned, there are many other causes and maybe much more common causes of blood in the urine, what we call medically hematuria. And this can refer, you know, to the common cause of UTI, urinary tract infection. That's probably the most common cause, or kidney stones, or some injury, trauma, you know, especially if there was a procedure done before, some inflammation, you know, in the urinary tract system, some benign kidney tumors, not necessarily malignant. Kidney cancer can be a separate cancer to think about, also in the urinary tract. Potential structural differences or variations. For example, there are some conditions causing significant number of cysts in the kidneys, what we call adult polycystic kidney disease, that can cause blood in the urine, or other variations in the kidney structure. Sometimes, as I mentioned, kidney stones is a common issue, but also higher amount of calcium, you know, in the urinary tract. Significant hypertension, especially what we call hypertensive emergency, can cause significant, concern because of blood in the urine, and also blood clots in the kidney vein or the kidney artery. There's some other more rare causes, like, you know, what we call variations in the structure of the blood vessels. And then there's some other causes that, you know, mimic or that make us think it is hematuria, but it's not, like menstruation, right? The menstrual period, the woman can see some blood and it's not clear where the blood comes from, especially if it's mixed with the urine, right? And some medications, phenytoin, for example, is sometimes given for seizures or other conditions. Nitrofurantoin, which actually is being given to treat sometimes urinary tract infections. There are some other, for example, foods like beets, right? Or other conditions like pigmenturia, a very rare condition where you have change in the color of the urine, or metabolic conditions, especially in kids. So there is a variety of other reasons, again, infectious, other cancers, kidney stones, trauma that can potentially explain this hematuria. But the bottom line is hematuria cannot be ignored. And I think there is very important message to the primary care providers to keep bladder cancer and urinary tract cancer in general in mind when a woman experiences hematuria, and quickly, early refer this patient to urologist for proper workup to make sure we don't miss a cancer diagnosis.
Exactly right. I think it's, when you look at this slide, you think about, boy, how complicated that 15-minute, problem visit might be in a primary care physician's office. And really then start to understand, some of the complicating factors that can come into this diagnosis. But you're absolutely right. I think we've all, met with women that, for some period of time were referred maybe to different subspecialists, but at the end of the day, ultimately it took a very long time to be referred to a urologist for what at the end of the day is a urologic complaint, right? Blood in the urine. So this is something that we all need to kind of keep on the forefront of our mind. So one of the things that has been, I think, really well reproduced is the time that it takes for men and women kind of at a population level to be diagnosed. So for men, on average, again, looking at retrospective, kind of going back and doing chart review studies, on average, it takes about 58.9 days, which is not at all short, right? But on average, a shorter period of time to complain of the first time having hematuria until getting into a urologist's office and then getting that actual diagnosis of bladder cancer. And the additional thing is that sometimes those urology visits need to be in sequence. So they may have already seen a urologist maybe at 20 days, but booking for an operating room time slot and then getting that diagnosis can take longer. But in women, really in every study that we've seen, that that time to the diagnosis can take longer. And we believe in part that is due to referrals, like actually getting a referral to go to a urologist or thinking on their own to go to a urologist, because I think a lot of women think of urologists as doctors for men and the OBGYN as doctors for women. And some, of our patients never even recognized that they could even go to a urologist if they wanted to. Again, not necessarily recognizing what that doctor does for a living. And so what happens during this period of time for the delay, the common things being common, some women may pick up the phone and say to their physician, having seen blood in the toilet for years before, in menses, or having previously had a UTI, say, there's blood in the urine, I think I have a UTI. And oftentimes they're just automatically prescribed antibiotics. And what we do know is that, again, in multiple different retrospective studies that we've seen, and this is an example of one of them, that women tend to have more urinalyses, more urine cultures performed, and more antibiotics prescribed when compared to men. And these are all patients who are ultimately diagnosed with bladder cancer. So we might not think a course of antibiotics is necessarily dangerous, and not that it is, but I think we'll talk a little bit about potential impacts on treatment a little bit later in the talk. So I think what happens during this period of time to women and men can be important. So how does this diagnosis come to pass? A patient will meet with a urologist in the office after having a complaint of blood in the urine. And then oftentimes the urologist can do an in-office procedure called a flexible cystoscopy, where they can just briefly use some numbing cream and then put a small camera into the urethra for men and women. If they see an abnormality and really feel like a patient needs a further workup and evaluation, if they do see a tumor, because often they can see it in that office evaluation, then a separate procedure needs to be done in the operating room where a patient needs to go under anesthesia and then have what's called a rigid cystoscope inserted into their bladder. And that's where a scraping of the inside of the bladder called a transurethral resection of bladder tumor, TURBT, can be done. That's a more challenging procedure and does need to be done under general anesthesia. So that explains a little bit also of the delay where it comes to actually getting that diagnosis. And we know that if we look at some older references, and the SEER database is a large kind of insurance-based database, but if we look at 1,865 patients that were ultimately diagnosed with something called non-muscle invasive bladder cancer, that muscle was kind of present in that biopsy specimen about half the time and absent about 30% of the time. And that's important to you and me because having that muscle in the specimen, it's really imperative to get that diagnosis. It's that line in the sand between whether or not someone's going to get treatment inside their bladder with a urologist, BCG, or whether or not they're going to see one of us and have a discussion about preoperative chemotherapy and bladder surgery to take out the bladder, or ultimately go on to get radiation. So that's a really important quality measure, but it's imperative for staging. And what's I think very important in this study is that for women, muscle was present much less often in the specimen than it was for men. Now, you and I are not urologists, but we've heard from our colleagues in urology that there are differences in the bladder between men and women, and that women tend to have these thinner bladders compared to men that have, thicker bladders. And in part, that can be based on the fact that many men can have something called BPH, or benign prostatic hypertrophy. and that just like any other muscle in the body, the bladder can get kind of bigger and bulkier over time. And that actually allows for, when they do this kind of very aggressive bladder scraping, to be a little bit easier in men than it can be in women. One of the risks of this procedure is something called a bladder perforation, where a hole can be put into the bladder. And that's a complication that, of course, people want to avoid. But it can then lead to what's called understaging. And so there are very significant differences in what we might do to treat a cancer if it's not staged appropriately. And we know that men and women have different presentation with later stage bladder cancer. Stage 3 is when the tumor kind of moves locally outside of the bladder, and stage 4 into lymph nodes, into other locations in the body. This is a CT scan, one of the ways in which we evaluate patients with bladder cancer. Petros, do you want to review this CT and just point out where, I can point out here in my, on my screen, where we're seeing this tumor.
Yeah, I think it's very important, I think, for the treating providers to look at the CAT scans themselves. And I think it's very important, to discuss with radiology, but also see the CT themselves. At this point, I want just to put a plug on our University of Washington multi-specialty bladder cancer clinic, that actually we have a tumor board real time with a medical oncologist like you and me, Ginny. We have a urologic oncologist, we have a radiation oncologist, a radiologist that helps us interpret those scans, and a pathologist that helps us really, really nicely intersect by the histology of the disease and look under the microscope in a search screen to see exactly what we look at. And this is very helpful. And we published a manuscript last year, and we saw that about 60% of patients, 3 out of 5, may have an impact in their treatment plan because of this multi-specialty approach. So to get to your example, you see a tumor there that is, as you point out in this arrow, in this rounded abnormality that is in the posterior part of the bladder, and it seems to be getting outside the bladder wall, or what you call extravesical extension. And that's important because it implies what we call a potential clinically T3 stage, that the tumor is outside the bladder. And this implies, at least radiologically by imaging, muscle invasive disease. And also there is a positive lymph node, that this rounded area, you see on figure B, that's a different, probably patient, but you see that the CAT scan can help us delineate the potential clinical stage, and the T3 versus T4, especially, when you have a large bulky tumor, T3, T4, may have implications in what treatment you do, especially if this is causing some blockage, what we call hydronephrosis, like a distension of the kidney because of blockage there, may have treatment implications in the decision tree. And also the lymph node involvement is important. To make another quick comment, because this is relevant in clinic, the clinical stage takes into account the exam under anesthesia that the urologic oncologist is, as well as what we call TURBT, the transurethral bladder tumor resection. As you pointed out, this is resection of the tumor in the bladder endoscopically by urologists for diagnosis and for proper staging to see how deep the tumor goes in the bladder wall. And imaging, CAT scans, for example, are important. So all these three together help us do the clinical stage, which is not always perfect, and we may not get the 100% correct. We may have a risk of not getting right, and the pathologic stage at the time of radical surgery, if that ever happens, if it's necessary, will give us a little bit more accurate staging information. However, not every patient needs radical cystectomy, radical nephroureterectomy, radical surgery, but whoever needs that and gets it, give us the pathologic stage, which is different than the clinical stage that we'll discuss right now.
Absolutely. I'm glad you brought that up too. We also, in many universities, do have this multidisciplinary approach to this disease, and it's absolutely essential that our colleagues from pathology, urology, radiation oncology, radiology, as well as other colleagues like palliative care. There's a whole special nursing unit that works with our patients, and yours as well, for the urinary diversion that happens. So there's a lot that really goes into the management of patients that have bladder cancer. So presentation, the stage at diagnosis really is very important. And we talked a little bit earlier about what we expect to see in all those 80,000 patients per year that are diagnosed with bladder cancer, most of whom have a localized disease. But for even with those patients, they can progress and have tumor that either recurs, comes back with time, or can become invasive or move or metastasize. Unfortunately, those that have a locally advanced tumor or metastatic tumor are at very high risk of dying of their disease. So this is very important for us to continue to work to find novel treatments to treat and hopefully cure this cancer. So you mentioned earlier, Petros, this important what's called clinical staging, the TURBT and the CT scan. Putting these things together is an imperfect way, but really at this point, the best way that we have of predicting what stage a patient has and then providing them with recommendations for treatment. And what what has been published, and I think what we've seen, unfortunately, as well, in patients that maybe have come to us later, are that women, and particularly women of a non-white race, are more likely to not have had this complete evaluation done. And whether or not that's a TURBT that doesn't include muscle, or maybe imaging that is incomplete and doesn't include certain parts of their body. This is, again, a retrospective study done in Medicare beneficiaries back in 2010. So this is something that we think is very important, that patients get complete staging. So this seems like a little bit of an off-topic slide. When you just take a look at the title, Gut Microbiome Influences Efficacy of PD-L1-based Immunotherapies. So since 2016, immunotherapy, these novel agents, PD-1, PD-L1 inhibitors, all different names for them, but they're becoming very well known in general society. President Carter just turned 96 years old, and I think in part because he was treated with one of these medications for his metastatic melanoma. They're approved for many different cancers, including urothelial cancers. But you know, it's interesting that as an anti-cancer therapy, you wouldn't necessarily think this, but these can be influenced by medications that our patients take. We know that sometimes high-dose steroids can impact how these medications act. But really, I think it was surprising to me, maybe surprising to you and others, that antibiotic therapy and how antibiotics that you might get for, say, a urinary tract infection, or maybe a urinary tract treated over and over again, can influence your outcomes to immunotherapy. So really interestingly, this was a publication done looking, again, retrospectively back in time for a group of patients that were treated that had non-small cell lung cancer, renal cell carcinoma, and urothelial cancer. And in the patients that had antibiotic therapy, their likelihood of having cancer progression and surviving was significantly better if they did not get antibiotic therapy in the time leading up to their treatment. So, Petros, I don't know what you thought when you saw these data, but I was just kind of blown away by this.
This is really important, you know, to point out that the science is really fascinating, and we both have been involved in studies, clinical trials, and translational research. And there is emerging data about the role of gut microbiome, and in actually the Bladder Cancer Advocacy Network, we have seen, you know, data in the last couple of years in our meetings, how the gut microbiome and prior use of antibiotics or even PPIs could potentially impact the effect of immunotherapy in urothelial cancer and in other tumor types too. And I think there are differences, as you mentioned, you know, between probably men and women, I assume, in the microbiome, and that could be a potential partial explanation of differential, effect or benefit, or even toxicity with immunotherapy in urothelial and other cancers. And there was interest because recently we saw two publications actually in a context of a large clinical trial. They went back and they looked at patients who received antibiotics or anti-acid like a proton pump inhibitor, and they showed some differences in the response rate to immunotherapy, with lower response rates in patients who had antibiotics versus not, and those who had proton pump inhibitors versus not. Obviously, when you have an indication, when you need to give an antibiotic for an infection, you have to do it, right? It's a clinical indication.
Right. Absolutely.
Inhibitor, you know, if it's a medical indication for a proton pump inhibitor or antibiotic, you have to do it, and you have to use a clinical judgment. So it's not that you have to, you know, avoid that doing it, but it just raises the scientific question well, what is the impact of those interventions in the microbiome, and then opens the door for more science, which I think is fascinating. And this science, can be, of course, important for both men and women.
Absolutely, and I think that this is an interesting time, an exciting time to kind of recognize all these different things. I think for patients and for doctors having that interaction, it is challenging because absolutely, when there's clinical indication, you need to use these medications. But oftentimes people, our patients hear about this really exciting research and then ask, well, what kind of gut microbiome should I have? And I say, we really don't know at this point. Yeah. We know that it's likely important, but hopefully in the next few years, and this is in part why the jobs that we have are so important and so interesting because of data like this that comes out that is a little bit unexpected. And again, I just point out, and we don't know for sure, but I just point out, we do then tend to wonder about our female patients who may have a delay in diagnosis and that are treated with antibiotic therapy. This is another study that just shows some very similar data that has come out, again, showing patients that had antibiotic therapy tend to have outcomes that were somewhat worse. Again, this is some additional data just showing some differences in staging, treatment, and delays to treatment, which may explain outcomes. And this is really, today we're talking more about women in bladder cancer, but we also know that a non-white race, as I had mentioned before, as well as patients having, private versus Medicaid insurance, all these things can really come into play. It's a tragic, I think, notion that that's true, but I think the recognition that different patients can have different outcomes really based on those things is something that is important to be recognized with the hope that we can overcome. This is not just a problem in the United States. So I think it's important to look at other countries, particularly those that have different healthcare systems than the United States has, and recognize that, here from a Scandinavian journal, that women, presented with more locally advanced bladder cancer than men did. So this is not just an issue in the United States. And I think that also points towards potential, biology as well in terms of some of these outcomes. With differences in overall survival depending on that stage. We know that, we talked a little bit about this delay in diagnosis and what does that mean, but we know one thing about bladder cancer is that a delay in diagnosis does affect outcomes. So from the time of a diagnosis of muscle invasive bladder cancer to the point where someone has a definitive surgery like a radical cystectomy, we know that delaying that time to surgery over a certain number of days, like around 3 months, can impact outcomes. And these are important data that you and I have known about for a long time, because we do delay surgery on purpose to give selected patients preoperative chemotherapy. We do that because it improves overall survival. But we want to make sure that we do that in a timely fashion. And if we notice that patients are having issues, we keep a watch on our clock, and we know about slides like this, which do indicate that delay can have an impact. And really importantly, that as I mentioned earlier, the other thing is, proper staging of bladder cancer. And I think that this slide is really so compelling, looking at patients that had muscle that was present in their specimen, so they are here, versus muscle absent in the specimen versus muscle not mentioned at all. Significant differences in their bladder cancer mortality, how likely they are to get diagnosed die of bladder cancer. And I think this really speaks in part, not necessarily in part to the staging as much, but to the fact that really clearly understanding the stage impacts outcomes, and that being in a place where this matters, and I think where then patients are getting multidisciplinary care, likely also affects outcomes. So really important that staging is done properly. Talk a little bit about non-muscle invasive bladder cancer. These are more what we call superficial tumors, even though these can become very dangerous tumors as well. So looking at gender-specific differences in recurrence in non-muscle invasive bladder cancer, this was what's called a meta-analysis, so a very large review of multiple different clinical trials done over years, 27 studies, 23,000 patients, just a dizzying amount of math. Overall, women were over 10% more likely to have recurrence than men, which is really compelling. And that's shown in part in these slides here. And the effect is really larger with longer term BCG. So if patients were treated with multiple cycles of BCG, that's that intravesicular into the bladder kind of bath of immunotherapy, that they had a higher risk of recurrence. This study from our colleague Steve Borgen, looking at over 1,000 patients who were treated with what's called induction BCG for multiple or recurrent high-grade bladder cancers. All patients had a 5-year follow-up, and they're looking at initial response to BCG, time to recurrence, and time to progression, and found that women compared to men had different outcomes, more likely to have, in this one, actually more likely to have lower stage bladder cancer, as well as less carcinoma in situ. So in this study, the women were about the same as men in terms of likelihood of recurrence and probability of progression. So, you know, when you look across the literature, I think it's important to see that not every single study shows that women uniformly do worse than men, which is important, and that may be related to site where they were treated as well. If we look at muscle invasive bladder cancers, those are tumors that are invading into the muscle layer of the bladder. We know that if, patients that have sex differences in tumors that are greater than or equal to T1, that's a superficial bladder cancer, again in Austria, outside of the United States, again based on over 27,000 patients. And looking at the risk of death, comparing women to men, when they had early stage bladder cancer, closer in terms of outcomes, but later stage bladder cancers, women tended to do worse than men when it comes to their risk of dying of the disease. And also shown here, looking at outcomes following radical cystectomy, again, for reasons we don't completely understand, that women tend to do worse compared to men. Whether or not this had an impact on their complications from surgery or their use of perioperative chemotherapy before and after, not clear. And again, another study showing that women had a worse outcome when they had bladder cancer surgery compared to men. This is yet another study done, published in 2014, looking at over 2,000 patients with what's called T4 bladder cancers, again, these locally advanced tumors. And this one showed that gender was not significantly associated with local recurrence, cancer-specific mortality, or all-cause mortality. So at least in that very kind of narrow window of a stage of T4 bladder cancer, even though there were more men in this study, which there always are because it's more common in men, outcomes not necessarily different. What about outcomes to anti-cancer therapy? So this is one of, I think, the only studies looking at sex disparities in the use of chemotherapy in patients with advanced bladder cancer. A lot of the studies focus on BCG. This was done by Tracy Rose, Matt Malowski, and our colleagues down at UNC. And they looked at the National Cancer Database, over 23,000 patients. Women tended to be older, and that's true. We know that women are older, presented with bladder cancer. They're more likely than men to be of non-white or African-American race, less likely to be insured, and they were less likely to receive systemic chemotherapy compared to men. So when you and I meet patients, we have a checklist in our mind about who we give chemotherapy to, either in the preoperative setting or in the first line setting, and who we think are not great candidates for chemotherapy. I think that you and I have that same checklist, but Petros, when you meet patients, what are some of the reasons that you think patients may not be the greatest candidate for chemotherapy, and why women might fall into that category more often?
Actually, this is a very puzzling phenomenon, and you know, we all strive very hard to eliminate disparities in terms of gender, in terms of minority population, race, you know, age, you know, and other, you know, based on education, healthcare literacy, insurance, income. I think we should strive for elimination of disparities, and we should promote healthcare equity. In terms of your question, how do we decide about fitness or eligibility for chemotherapy? In both men and women, there are certain criteria, and Dr. Shilpa Gupta, one of our colleagues, who is now in Cleveland Clinic, along with Jonathan Rosenberg in Memorial Sloan Kettering. They try to work with all of us and do a consensus survey to help define these patients who are not fit for chemotherapy. And the few themes came out: patients with very poor performance status of ECOG PS of 3 or higher, very poor kidney function, GFR below 30 ml per minute, combination of ECOG PS2 and GFR below 60, very significant neuropathy grade 3 or higher. These are potential, things you look at and you take into account. Obviously, in the clinic, there are other issues like frailty. We have geriatric assessment tools that we have seen with ASCO and other tools that will help us evaluate the fitness of a patient. The social support, the nutritional support, the motivation of the patient, the engagement, and mainly the physiologic age, right? Not only the chronologic age, but the personality. All these factors are taken into account, and my colleague, Dr. Sarah Sutka at the University of Boston, is working very hard to try to come up with objective information, how we can make this determination more objective and less, subjective. We all use like the eyeball check. How can we make it more objective?
Right. So, and we use a medication, very toxic medication, but powerful medication called cisplatin. That's the medication that you and I would use, that we would all agree on, and our urology colleagues, to delay surgery by a certain period of time to get cisplatin. And you really have to be very fit. You have to good cardiac function, because we give it with, copious hydration pre and post cisplatin. You have to have a good hearing, because the cisplatin can affect hearing. Peripheral neuropathy, as you mentioned, numbness and tingling in the fingers and toes. If you have it at baseline, that can get significantly worse. We don't want people falling and being at higher risk. All our chemotherapy causes fatigue. So if patients are so impacted by their cancer, they have a hard time even walking into clinic. We know that they're at higher risk of having complications. So, and then of course, finally, kidney function. So our treatments are potentially toxic to the kidneys, but at the same time metabolized by the kidneys. So all these things that we look at, but there's nothing necessarily about women that makes them at worse risk of getting those complications, compared to men. But I think something really to keep in mind.
I agree with you, and to your point, there are certain criteria, what we call the Gauss criteria, specifically for cisplatin, that you mentioned it very well. And then the additional question that we try to get into with Dr. Gupta, you and others, about the overall chemotherapy fitness, the what we call platinum cis and carboplatin fitness. And there are some differences there, but you're right. We should try to evaluate why we have these disparities in gender. We should do a good job in finding this out.
Absolutely. So this was another compelling paper that came out a couple of years ago in Lancet Oncology, looking at cancer immunotherapy efficacy and patients' sex. So this was a study looking at multiple different clinical trials that were done prospectively or come forward in time, and then looking backward in time at an outcome that wasn't necessarily kind of intended to be measured, but what these authors did is kind of pulled all these different papers and data together, looking at over 11,000 patients with metastatic cancers. The most common were melanoma and non-small cell lung cancer. There were not patients that had bladder cancer in this paper, but the poll analysis did show that men tended to kind of do better compared to historic controls with other kinds of treatment like chemotherapy compared to women. So essentially they had a bigger kind of improvement in what would be expected if they were treated with chemotherapy compared to women. And I thought, this is really interesting. We don't know why this is, and there's certainly no patients with bladder cancer in there. So, can we do the same and look at patients who with bladder cancer who were treated with the same thing with immunotherapy? So what this poster was, and this is a paper now that's under review that was done by our group in conjunction with our colleagues at Genentech. So Genentech makes the drug called atezolizumab, one of the 5 medications that are FDA approved for urothelial cancer. And we looked at all of their different studies that were done in urothelial cancer over time. In Vigor 210 cohort 1 was in patients that had not previously had prior chemotherapy. All the rest are in patients that had chemotherapy. And although none of these studies showed a difference that was statistically significant between men and women, there was this trend that kind of came across that men tended to have a better response, or more likely to have response to immunotherapy compared to women. Now, you and I know that response, meaning kind of absolute shrinkage of a cancer on immunotherapy, doesn't necessarily mean the same thing as it does in chemotherapy. You know, in chemotherapy, I think of chemotherapy like a big hammer. You're hammering the cancer cells. Unfortunately, the person that has the cancer also has a lot of the side effects from the treatment. But you expect one thing with chemotherapy in someone that has metastatic disease, that the cancer will either shrink down or at least stay the same size. And that's your measure of success. But with immunotherapy, the kinetics, or what we expect to see from the cancer, can be somewhat different. So I think this is what we call hypothesis generating data. So this, to me, just means that there's something probably more that we need to look at. And I think one of the things, and Petros, correct me if I'm wrong, but I don't know any studies that have been done in bladder cancer where the primary outcome of the study is looking at differences between how men and women respond to treatment, or different, yeah.
That's right. It's an unmet need, and I think it's an opportunity for research, to your point, Jimmy.
Yeah, and we talk about clinical trials a lot because every single treatment that has been, all these great new treatments that have been FDA approved since 2016, because for decades before that, we had no new drugs that were FDA approved. All of these different agents, therapies given in different, what we call spaces in the disease, we know to give them because of clinical trials and because of our patients that have been willing to sign up to be a part of those clinical trials. So really important. In the last few minutes, we'll talk about molecular subtypes. So bladder cancer is not all one disease. We know that bladder cancers can arise from different parts. This is the inside part of the bladder, the part that meets the urine. This is more towards the bladder wall. We know that these are different kinds of cancers that can arise, and that men and women tend to get different kinds of what we call molecular subtypes of bladder cancer. So women tend to present with this more what's called basal squamous type of bladder cancer. We know that they can do worse over time. They have different molecular makeup and may respond to different kinds of therapy. So the more that we do, the more that we can kind of figure this out. There have been multiple different groups that have tried to kind of subset bladder cancer into different categories. And we know that women tend to have this, again, basal squamous subtype. It's not necessarily 100% at all. But when you characterize the different mutations or changes in bladder tumors, women tend to fall into a category where they tend to have that character to the bladder cancer. And then finally, let's talk about what's called the androgen axis. So men and women are different because of the different hormones that are produced in the body at different times. And some research has been done, I think definitely room for more, but some has been done looking at something called androgen deprivation and the androgen pathway. So androgen deprivation is a treatment that we use for men with prostate cancer. So prostate cancer is a tumor that can respond to changes in the hormone pathway. And one of the kind of standard recommendations for someone with a new diagnosis of metastatic prostate cancer is to decrease the amount of testosterone that's seen in their system. We do see patients that have both prostate cancer and bladder cancer sometimes diagnosed at the same time or in sequence. And so what this study did was really capitalize on that and think about patients who were treated both with prostate and bladder cancer, and then how did their prostate cancer treatment affect their bladder cancer. And lo and behold, what they found was that patients who got ADT, which stands for androgen deprivation therapy, their chances of having their bladder cancer come back, and most of these patients had superficial bladder cancer, was really significantly lower than patients that did not. Again, really compelling data. And one of the things that we know as we learn more and more about bladder cancer is that bladder cancers can, not always, but they can express something called AR, or the androgen receptor, on the surface, and then may or may not be receptive to medications like androgen deprivation therapy. This also looks at the risk of cumulative recurrence, which was lower in that group of patients. This was another paper done looking at non-muscle invasive bladder cancer, showing that in patients that had the androgen receptor present, and that's the target for ADT, those that got ADT tended to do better than those that had the androgen receptor that was not present, which makes sense. Other papers too have shown the same thing. This is looking at men with non-muscle invasive bladder cancer and prostate cancer treated with, again, androgen suppression therapy, that's AST here, having an improvement in their recurrence-free survival. And another drug which can affect the androgen pathway called Finasteride looked like it improved survival probability in patients that had bladder cancer as well. So these are really compelling data. How are we using these medications in clinic? The answer is no, we're not. But there are definitely studies being done. Again, you mentioned our colleague Shilpa Gupta, who's now at the Cleveland Clinic. She had one of several clinical trials looking at enzalutamide, which is a drug that is used for men with prostate cancer, but then translating that into bladder cancer. And I think it's something that we think about more often so in use of medications for one cancer, and how can that be translated into another cancer. And this was really, I think, a very interesting study that Dr. Gupta did. Another study that's being done looking at a breast cancer drug called tamoxifen. I want to start to close about our mission, and here at Hopkins, as well as several other centers across the country, really recognize this disparity between men and women. And so one of our missions is to really understand and have an impact on the outcomes in women that have bladder cancer. There's so many more, I think, facets of the differences between men and women to talk about. We have special support groups to talk about this as well. Life after urinary diversion, including sexual outcomes and continence outcomes, really important things that really women want to talk to other women about and not have men in the room. And I think being a woman and going through a diagnosis and treatment for bladder cancer, especially as you may be the only woman in the waiting room of the urology office, can be somewhat isolating. And so having the opportunity to meet with other women with this disease has been really important. So in summary, looking at the differences between men and women have the same symptoms at presentation. Women have a longer time to diagnosis and more non-urology referrals before they're diagnosed. They tend to have a less complete evaluation if we look at all the data that's been published about this. Hopefully not, as that data gets published and people change their practice, hopefully this is no longer the case. Women tend to have a later stage of presentation, and I think this is still true. They may get less therapy, we don't understand why. They may have a different response to therapy, we still don't understand why. Women have a higher age at presentation. Impacts of the hormones may certainly come into play, and tumor biology does seem to be different. How does this change our standard of care? The answer is it doesn't at this point, but I think understanding and recognizing these differences and continuing to do research in the different spaces remains very important. All these different things we have identified as targets that we can potentially impact: delaying diagnosis, antibiotic use, staging, and awareness. And these are some options of things that we can do to impact that. And I think, to get back to our introductory slide, definitely things to do for awareness, like Dr. Graves' orange t-shirt and BCAN and the walk to raise awareness for bladder cancer, really, really important. How patients are handled when they are seen in the office, how patients experience this biology, and then finally really understanding more about biology, ways in which that we believe that we can make inroads into this disease in the future. Dr. Graves, do you have parting comments here?
Ginny, I think you raised very, very important multiple points that I think we should follow up on, and both you and me are committed in this mission, along with the Bladder Cancer Advocacy Network and many other colleagues, patient advocates, foundations, institutions, and as you mentioned, this is a priority. I think clinical trials is another very important domain. We try to eliminate disparities in the accrual of patients there and have both genders, as you pointed out. And also, in the investigators, right? You're an example of a very successful woman who does great research in bladder cancer, and there are many others, right? So I think it's both of the, spectrum, aspects to have women represent in clinical trials space, and also investigators. I think overall it's a great opportunity for us to promote healthcare equity. I'm glad we're doing this presentation together, and I look forward to working further with you and many others in the field to eliminate disparities, including gender disparities in bladder cancer. Thank you for collaborating in this mission, Jenny.
Thank you, and thanks for the conference organizers for having us. The good news is that you and I are not the only people across the country who are interested in this. So we have many colleagues who are collaborating, with us and others looking at this problem and this issue. And then, of course, as we mentioned before, our friends at Beacon, the Bladder Cancer Advocacy Network, have a lot of interest in this well, and they're doing their part to raise awareness for women with bladder cancer. Thank you.
Thank you so much.